Hello and namaste to all of you. This is Name-Shalu Singh from Department of Physiotherapy and Diagnostics from Jayoti Vidyapeeth Women's University. So today I'll be discussing with you about potential errors in measurement of glycosuria. So firstly, let's go through what is glycosuria. So glycosuria or glucose in the urine results from the glomerular filtration of more glucose than the renal tubules can absorb, and it occurs in all normal individuals in amounts up to 25 mg per day, and abnormally increased like glucosuria, so more than 25 mg per day in random fresh urine, so results from either an elevated plasma glucose, an impaired renal glucose absorptive capacity, or both. Now, the plasma glucose concentrations above which significant glucosuria occurs is called renal threshold for glucose, and its value is variable, and deviations occur above both above and below the commonly accepted normal threshold of 180 mg per day. Now, in diabetic patients, the value is reported to vary from 54 to 300 mg per day. And although glucosuria greater than 25 mg per day is considered pathologic, many commercial semi-quantitative urine tests for glucosuria are available to patients fail to detect glucosuria until it reaches the level of 50 to 250 mg per day. The association of blood and urine glucose was first observed in 18th century. Matthew Dobson, an English physician for many years, and urine glucose testing was the major method used for monitor glycemic control in diabetes mellitus. And early methods for urine glucose detection included evaporation of urine to reveal sugar crystals and urine sugar fermentation by yeast, and methods based on copper reduction was developed by von Felling in 19th century and by Benedict at the turn of 20th century. And in 1841, the Ames company marked the Cleany test a copper reduction method, and following it with Cleanistics, a glucose oxidase based determination. And since then, several companies have marked glucose oxidase based test. Measurement of glucosuria is an indirect index of blood glucose concentration, and the test for urine glucose must be interpreted with caution, and technical issues such as test sensitivity and variability for renal glucose threshold must be taken into account. And furthermore, the social stigma sometimes associated with the handling a body waste product can be consideration in terms of patient acceptance of monitoring technique. Now, these limitations, together with the development of home blood glucose monitoring, have led to a decline in use of urine glucose for monitoring in diabetes mellitus. Self-monitoring for capillary blood glucose is now the preferred method. Nevertheless, assessment of glucosuria produces and it is especially appropriate monitoring of tool in health and care testing, where socio-economic or educational constraints preclude the use of more sophisticated techniques, example home capillary blood glucose monitoring and glycosylated hemoglobin measurement, and frequent plasma glucose determinants. And selected patients continue to find urine glucose testing convenient, non-invasive, inexpensive, and useful. So, in previous sections, I've told you about the various techniques that come under the qualitative analysis of urine. So one of the most used techniques is your cleanistics, and that of your chemi strip and diagnostics and test tape. So there are various problems that are encountered during the measurement of glucosuria. So there is considerable literature about the substances that are alter the validity of of tests for glucosuria, and conflicts report often results from the effect of different concentrations of substances in question or subtle methodological differences in test procedures. So, however, achieving a urinary concentration of substances that can alter the test is often difficult under normal clinical substances. And in addition to drugs, limited evidence suggests that other agents such as nalidic acid, probenecid chloral hydrate, hyaluronidase, nitrofluorentoin, PAS, phenazonopyridine, iodinated radiopaque agents, they can interfere with the urine glucose testing, and ciprofloxacin, which is a quinolone antibiotic related to nalidic acid, does not interfere with Pliny test and has been associated with false positive reactions in certain glucose oxidase tests. And practical issues can also alter test results, with clinitest angling of the dropper away from the vertical and can alter volumes that are critical to accurate results. Now, timing and shaking can also alter available oxygen and modify the reaction, and inattention may cause to be missed of nurse miss 58% of nurse routinely performing simultaneous clinic test and AC test procedure fail to recognize the pass-through phenomenon and the potential errors in monitoring glucosuria. So the errors in color discrimination occur frequently during glucosuria monitoring. So, patients of all age groups and professionals read more accurately at the extremes of urine glucose concentrations, and accuracy decreases as the true value approaches the mid range of the test. Now, the most errors for all groups are underestimates. Healthcare professionals have been trained to balance the error distribution, implying that the errors are not inherent to the test procedures. So, the acquired color vision deficiency caused by diabetic retinopathy itself may contribute more to inaccuracies in glucosuria testing than any other factor. So, it is primarily a blue yellow defect, and therefore it involves more tests for glucosuria, and severity of diabetes related defects correlates significantly with overall severity of diabetic retinopathy as well as with the severity of macular disease, and this effect has of diabetes is severe enough to mask the normal loss of hue discrimination which occurs with age. And however, hue discrimination can alter with ambient light as well as by age. So, reduced lightening can decrease the huge discrimination people with normal color vision. Although testing in bright lightening did not approve results in non-diabetics, and results from diabetic individuals improved significantly. So patients with a proliferative diabetic retinopathy or diabetic macular disease are probably at higher risk for test errors when monitoring glucosuria. Now, errors can also stem from a fallacious concept of a normal and renal threshold. So, real variations in renal threshold for glucose among the individuals is a significant reason why patients and healthcare professionals find urine tests misleading and are frustrated with the data generated. So, further, there is a significant trend of patients with higher renal thresholds for glucose to exhibit higher values for glycosylated hemoglobin and mean blood glucose because glucosuria testing cannot warn of hypoglycemia. So diabetic patients tend to maintain results at near threshold values, and therefore, in those patients who aim for tight control, glucosuria testing should be abandoned when results are consistently negative, and once management has got blood glucose to the point of absent glucosuria, there is no alternative to capillary blood glucose monitoring. So the basic glucosuria basic science behind glucosuria can be that although small amounts of glucose are present in urine, all normal individuals, the term glucosuria is conveniently reserved for pathological amount of urine glucose, more than 25 mg per year, and random fresh urine. So the renal tubule will reabsorb almost all glucose present in normal glomerular filtrate, and glucosuria occurs when that balance is lost when amount of glucose in glomerular filtrate exceeds the capacity of renal tubule to reabsorb it, and the balance can be lost either when the plasma glucose is elevated, example in the case of your diabetes mellitus, or when the absorptive capacity of tubule is impaired, so which is example in case of a Fanconi syndrome in your pregnancy, hereditary and renal glucosuria, and in case of your acute tubular injury. Now, various clinical significance of glucose measurement for measuring glucosuria can be. So the measurement of glucosuria is potentially satisfactory for the relatively stable patients with diet or oral agent control type 2 diabetes mellitus who infrequently require management adjustment, particularly if used in conjunction with periodic assessment of plasma glucose, glycosylated hemoglobin or fructosamine levels. So because of its insensitivity to hypoglycemia, urine glucose testing cannot be generally recommended as a basis for making therapeutic decisions in patients with type 1 diabetes or in tightly controlled type 2 patients taking insulin. So it is also inadequate for use in management of diabetes in pregnancy. So, however, urine testing in these patients remains necessary for ketones, and a quantitative 24-hour urine glucose determination is advocated by some as means of assessing glucose control and dietary compliance. So, a reasonable goal in excretion of less than 7% of ingested carbohydrate per day. So, the excretion of much greater amount is asymptomatic, non-ketotic diabetic, suggests dietary non-compliance, and measurement of glucosuria is inexpensive and non-invasive, so patient acceptance of a responsibility for monitoring glucosuria can contribute to improve control. And in one study, the mean blood glucose value was significantly lower in patients who complied with glucosuria monitoring instructions than in those who did not. So, in patients with whom capillary blood glucose monitoring is impossible or impractical for any reason, we accept and work with the limitations of monitoring glucosuria in order to achieve the benefits which monitoring can offer. So, that was all about the problems that I encountered with glucosuria measurement techniques. So, if you have any doubts regarding glucosuria, you can contact me. And until then, take care and goodbye.